Welcome to the June 2024 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. My name is Mike Rickles from the University of Pennsylvania.
And I'm Alice Chang from the University of Toronto, and we are your co-hosts for this podcast series.
As per usual, Alice and I will interview authors of feature articles as selected by the editors of Diabetes Care, followed by our rapid exchange segment where we give brief summaries of articles we found of particular interest.
Now, before we share a fun fact about June, I want to remind our listeners that in the May episode, I challenged Mike to take a video of himself appropriately celebrating Dance Like a Chicken Day on May 14th. Now, Mike, I'm still waiting for the video.
Well, I know I'm being a disappointment, Alice, but I do have an excuse. I spent May 14th packing up and returning home my second of 3 college-age kids, which regrettably did not leave time that day for any chicken dancing.
Excuses, Mike. It's okay. Next year.
Well, it is June now, and that does mean time for the annual ADA scientific sessions that will take place later this month from June 21st to the 24th in Orlando, Florida. Alice, once again this year, you served as chair of the Scientific Planning Committee. So I want to ask you anything to highlight for our listeners.
Well, Mike, I may be biased, but I'm going to say that this year is going to be another fantastic meeting. More than 200 sessions and 1,400 posters will be presented. We'll kick things off with a keynote lecture from Dr. Robert Califf, who is serving as the 25th Commissioner of the Food and Drug Administration, or FDA. There will be inspirational award lectures as usual. And this year, we've got the Banting Lecture by none other than Professor Rory Holman, the Outstanding Educator Award Lecture by Dr. Joshua Newmiller, and the Outstanding Scientific Achievement Award Lecture by Dr. Stephen Parker. And as per usual, we'll witness first-in-world presentations of data from multiple clinical trials, and I'll just name drop a few. We'll hear from the ATTEMPT trial, which is of SGLT2 inhibitors in youth with type 1 diabetes, INHALE-3, which is a study of inhaled insulin in type 1 diabetes, the TITE study, which is that of CGM versus usual care for type 2 diabetes in hospital, and the CATALYST study, which is a study of therapy for hypercortisolism in type 2 diabetes. And then on top of that, we're going to see new data from the FLOW study, STEP-HFpEF-DM, SELECT, as well as SURMOUNT-OSA, just to name a few. And if that weren't enough, there will be panel discussions, debates, Ask the Experts, and professional development sessions. And one of the panel discussions that I'm particularly looking forward to will discuss the controversial topic of perioperative management of incretin-based therapies. So I encourage everyone listening to register for the meeting, be it in person or virtual, and connect with the global diabetes community.
Well, that just sounds incredible, Alice, and congratulations on getting to this point with the meeting teed up and ready to take off in just a few weeks, a month from when we're recording, but a few weeks from when this episode airs. And I'm really looking forward to attending myself. On that note, let's get started with the content for the June 2024 issue of Diabetes Care. In the June 2024 issue of Diabetes Care is a feature article entitled Severe Hypoglycemia and Impaired Awareness of Hypoglycemia Persist in People with Type 1 Diabetes Despite Use of Diabetes Technology. Results from a Cross-sectional Survey. We have joining us the article's first author, Dr. Jennifer Sherr, and the article's last author, Dr. Jeremy Pettus. Dr. Sherr is professor of pediatrics in the Division of Endocrinology and Diabetes at Yale University in New Haven, Connecticut. And Dr. Pettus is an associate professor of medicine at University of California, San Diego. Welcome, Jen and Jeremy. I'm delighted you could both join us.
Thanks, Mike.
Thanks so much, Mike. Really happy to be here.
Well, congratulations to you both and your colleagues on this feature article. So, clinical trials of advanced diabetes technologies, namely continuous glucose monitoring or CGM, insulin pumps, and now automated insulin delivery systems, or AID, have all demonstrated improved glycemic control in type 1 diabetes without increasing risk for hypoglycemia. And in fact, trials involving those at increased risk for hypoglycemia have shown reduced time spent with hypoglycemia and reduction in severe hypoglycemia events without requiring the permissive hyperglycemia that has been recommended in our standards of cares for the avoidance of hypoglycemia. However, we all know in our clinical practice that not everyone treated with advanced diabetes technologies is achieving recommended targets for glycemic control or able to avoid or eliminate experiencing severe hypoglycemia. So I was hoping, Jen, you could take us through how you set out to evaluate this problem using real-world data.
Thanks, Mike. So absolutely. I think we have data, obviously, from clinical trials that are done, but what happens in the real world is really important and impacts what we expect to see in clinical care. And so to get at the heart of this issue, the decision was made to create a survey. And they decided to go ahead and target certain communities that we know have been engaged with the type 1 research in the past, specifically the T1D Exchange Registry, and then some T1D Exchange online communities. And so there was a survey that was distributed with the hopes of having about 2,000 participants respond. And clearly, with the simple survey where there's self-reported data provided, we were able to reach that goal in terms of the numbers we achieved.
Great. So among your more than 2,000 survey respondents, 92% were CGM users. And for insulin delivery, 17% use multiple daily injections, 28% standard pumps, and 47% AID. The overall average hemoglobin A1C was 6.9%. So as a population, this group seems to be doing quite well. Jeremy, turning to you now, what else can you tell us about the study group? And is there anything that makes these participants unique beyond where they were recruited for participation?
Thanks, Mike. So I kind of think of this population as kind of like, for lack of a better word, the best of the best, right? These are people that are seen through the Type 1 Diabetes Exchange Network. So they're seen in some of these kind of premier diabetes clinics. They clearly have access to care. 92% are on CGM, about half them on AID. And plus, these are people that are taking time to respond to a survey. So these are kind of like plugged in, engaged people with Type 1 diabetes. And we wanted to ask the question in this group with this kind of high tech utilization, how are they doing? Because I think there is a perception in the Type 1 community, or actually beyond the Type 1 community, and diabetes in general, that these AID systems have just kind of solved Type 1 diabetes, that people don't get highs and lows anymore, and it's kind of a wrap. So we wanted to ask this very kind of plugged in, group, is that the case? How are they doing? And we'll get to some of the results, but overall it shows that tech is useful, that people do better, have better blood sugars, less hypoglycemia when they use CGM and AID. But there's still this kind of high, what I would call residual risk of people having hypoglycemia, et cetera, that we'll get into. And I think it's so important for the community to know about.
So this is a really highly engaged, plugged in community of patients, big uptake on advanced diabetes technology use, and from the overall A1C, doing quite well by overall measures. But as you point out, Jeremy, may still have residual problems with managing their diabetes. And so with that, severe hypoglycemia events were reported as occurring once or more in the past year by 20% of respondents and twice or more by 12% of the respondents. So Jen, I'll turn back to you now and ask if this high rate of severe hypoglycemia, did this surprise you given the population? And can you take us through what you learned about the association for use of the various advanced diabetes technologies on the severe hypoglycemic event rate?
Yeah, so I absolutely was surprised by the rates of severe hypoglycemia, especially for the individuals who are having more than one episode a year. I think that was really eye-opening. I think many times in clinical practice, we try to solicit these events, but we may not always get to them. And so people are anxious about talking about them, fear of being judged. A survey where it's not going to be associated with, did I do something wrong with my tech? Maybe people are a little bit more able to respond fully to the question. And so I think the thing that's interesting is clearly when you take a look at our figures, we see that those who are on CGM, obviously there's a benefit. There's a reduced rate of severe hypo events reported by those participants on CGM. But what was interesting is that, pump and AID therapy didn't completely take away that risk. And as Jeremy just pointed out, there are limitations with AID and these advanced insulin delivery technologies. Individuals can bolus and not eat, or eat less than they assumed they would. There can be rage bolusing. And so we have not yet overcome all that can occur that can lead to severe hypoglycemia, making it critical that we as providers are asking about it, figuring out what's happening to the individuals. And I think specifically for those who are having more than one hypo event, how do we protect them as best possible? And how do we ask the questions to allow them to share this information with us?
That's great, Jen. And also, quite interestingly, in this survey, impaired awareness of hypoglycemia was present in 30% of respondents across all groups of technology use. And so to me, that says technology use may have benefits in terms of reducing hypoglycemia, limiting the number of events, albeit there is this residual risk for complications related either to use or behavior surrounding insulin bolusing, et cetera. But I was, surprised that we haven't really reduced the ability of individuals to recognize when they're low outside that of, say, the reduction related to CGM and this concept of technological awareness, but that the response of impaired awareness of hypoglycemia was so prevalent. So, Jeremy, I'll turn it back to you and ask if you were surprised by this, and what do you think might explain this?
Yeah, I mean, these numbers are concerning overall, right? I mean, Jen just went through that roughly 20% of these participants had a severe hypo in the last year. And then about 30% of people reported an impaired awareness of hypoglycemia. And that was a modified GOLD score. It was one question that we basically asked them that defined if they're aware or not. So there are maybe better ways of assessing this. But the point being that 30% of the people identified themselves as being unaware of hypoglycemia. And again, Mike, as you mentioned, that it didn't really change by group. CGM on MDI, CGM on, kind of a regular pump, CGM plus AID. So it's tempting to infer from this that, going on AID doesn't restore awareness, but we can't really say that. I mean, obviously this wasn't an interventional trial. And Mike, you and I are involved in the large kind of NIH consortium called the CLEAR study that's really actually looking at this in a prospective manner. If you take unaware people and put them on advanced technology combined with education, can you restore awareness? Because this is so critical. I mean, these are the people we worry about the most, right? The people that are unaware are the highest risk for a poor outcome. So we want to do something about this. And these numbers are really kind of alarming.
Absolutely, Jeremy. And I think that's exactly the point, that we need to continue to identify who the individuals are who are having problems and are at increased risk for future severe hypoglycemic events, including those with impaired awareness of hypoglycemia, that we may be paying less attention to now with the advent of use of the alarms, alerts, and automated suspensions and so forth, but that there's still a group of our patients who are continuing to struggle with this. And so, Jen, Jeremy, what can you share about other next steps for this population and any other final takeaway messages you have for our listeners?
So in terms of next steps, we do have another manuscript that we're about to submit, looking specifically at the CGM data that was collected along with the survey data from a subset of these participants. So we're excited to be able to publish and share that. Additionally, at this year's ADA, I will be presenting an oral presentation with prospective follow-up of a cohort of these individuals, again, looking at rates of severe hypo, impaired awareness, and digging into a little bit more what happened with those severe hypo events. So I'm really hopeful people will come and check that out. I think that in terms of a takeaway for me, when people are answering modified GOLD, they're picking a number somewhere on that spectrum and saying go. And I think that in clinical practice, I was in clinic this morning, one of our standard question is, do you feel low if you're less than 70? And we have to keep asking questions. We have to keep exploring. We have to keep finding out what the lived experience is, because if we just assume tech is taking care of it all, we're missing a huge part of what's going on in those we treat and their lives.
Yeah, and I'll just add on, I agree with everything that Jen said as usual. For me, for this particular manuscript, it was very important for me and for us to be very clear that we are huge proponents of technology. CGM, AID systems, these have been just huge advances, but there's still work to be done. So I wanted to be very careful that this didn't come out as some kind of anti-tech or, that kind of thing. No, tech is hugely beneficial, but there's still, people that are dealing with hypoglycemia, dealing with hyperglycemia, et cetera. So God bless technology. I think it'll continue to evolve and get better. Personally, I think this just opens the door for maybe other metabolic therapies for type 1s, obviously other cure-based approaches. So these things all go kind of hand in hand to truly kind of move the needle in type 1 diabetes care to get people to live a long and healthy and kind of safe life.
Well, that's really remarkable, and I'm delighted to hear the next steps coming with the CGM data you mentioned, your upcoming presentation. And Jeremy, the CLEAR study is going to, I agree, certainly provide a wealth of information for how to best approach individuals with residual problems with impaired awareness of hypoglycemia, those with exposure to hypoglycemia, despite the use of advanced diabetes technologies, which really have helped a tremendous portion of our population living with type 1 diabetes. But there's room for improvement, especially for an important subgroup of our patients. And so, Dr. Jennifer Sherr and Jeremy Pettus, thank you both so much for sharing your expertise with us today. I really appreciate all I've learned from your paper about persistent problems of severe hypoglycemia and impaired awareness of hypoglycemia affecting some of our patients despite implementation of advanced diabetes technology. And this really does highlight an unmet need requiring further clinical investigation. So I'm delighted to see where that is going to be going in the near future. And I encourage our listeners to access the full article in the June issue of Diabetes Care.
One of the feature articles from the June 2024 issue of Diabetes Care is a Perspectives in Care piece entitled The Glucose Management Indicator, GMI, Time to Change Course, by Professor Liz Selvin, who is a professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health, with a joint appointment in the School of Medicine Division of General Internal Medicine, and also newly appointed director of the Welch Center for Epidemiology and Clinical Research at the Johns Hopkins University. And if that weren't enough, Liz is also a deputy editor for the Diabetes Care Journal. Thank you for agreeing to be part of this podcast, Liz.
Thank you so much for having me. I'm really excited to be on the show.
So first of all, I just want to say a thank you from me personally to you for all the great work that you've done so far in your career, really helping us to better understand the epidemiology of diabetes, cardiovascular, and kidney diseases. Very much appreciated, and I'm certainly a fan. So thank you for everything that you've been doing.
That's kind of embarrassing.
No, but I did that on purpose. Now let's get to this latest Perspectives in Care piece that you've written about the Glucose Management Index. Now, I got to admit, this one might ruffle some feathers, which is why I really wanted you to be on the podcast so we could actually discuss this further. And to start, and maybe to level set for all of our listeners, can you briefly explain what is the Glucose Management Index and some of the historical context for why it was developed? And just as a side note, when this first came out and there's talk about the GMI, I was so immersed in that SGLT2 inhibitor space. When I heard GMI, all I could think about was genital mycotic infections. And it took a while for me to sort of flip my brain and go, no, we're talking GMI, the other GMI, the Glucose Management Index. So for our listeners, we're talking about the Glucose Management Index, not genital mycotic infections. So Liz, back to you. Historical context, what is it? Why was it developed?
Sure. And, you always have to be careful with abbreviations, right? I mean, you can get into serious trouble because your abbreviations are not my abbreviations. Okay, so sure, the Glucose Management Indicator, or GMI, was originally developed to help translate glucose from continuous glucose monitors into an estimated hemoglobin A1C value. So the reasoning behind this is because for over 3 decades, the laboratory test hemoglobin A1C has really been the cornerstone of diabetes management. And we know that lowering hemoglobin A1C reduces the risk of major diabetes complications. So our glucose control targets are all based on hemoglobin A1C, not continuous glucose monitoring. But of course, the use of continuous glucose monitoring, or CGM, that technology has revolutionized the care of patients with diabetes, as you well know, and primarily people with type 1 diabetes. So there's really this big interest in tying continuous glucose monitoring results, CGM results, to current glucose targets, which are all based on hemoglobin A1C. And so GMI is simply an equation that translates mean glucose from your CGM into an estimated hemoglobin A1C value. And the idea being that everyone is familiar with hemoglobin A1C. So if we just provide patients and doctors with this familiar A1C-like value, that this would help simplify things.
So, what made you start to question the utility of the GMI then?
Yeah, well, there's been now a whole bunch of studies where investigators have compared GMI, this estimated hemoglobin A1C, to real laboratory hemoglobin A1C. And these studies have been done in many different populations of people, both with and without diabetes, people with type 1 diabetes, people with type 2 diabetes, young people, old people. And it turns out GMI and laboratory hemoglobin A1C typically don't line up very well. So basically, that GMI is not actually a very good estimate of hemoglobin A1C.
Now, I thought one of the reasons, though, that they called it the GMI and changed it from, because the reports used to say estimated A1C, and then they changed it to GMI was to help deal with some of that confusion. I thought that that was my understanding of why they did that. So when you dove deeper then into the question of this discordance, what did you find?
So when GMI and hemoglobin A1C don't align, often people blame hemoglobin A1C. And I think, the prior iteration, which was called estimated hemoglobin A1C, was particularly confusing because you'd have one hemoglobin A1C and another hemoglobin A1C. So now we have a GMI and then a laboratory hemoglobin A1C. And so I think that's a real source of the confusion. And so, there's this temptation that people, we have this discordance and you're like, oh, well, something's wrong with the hemoglobin A1C. And that's really been a message. So that's a real concern I have. And so one of the things that we provide in the paper in Diabetes Care is some data from one of our studies where we had 200 participants wear 2 different CGM sensors at the exact same time. And what we found is that GMI from one sensor was sometimes very different than GMI from the other sensor. Obviously, those differences had nothing to do with hemoglobin A1C. So the reality is that there's actually a lot of unappreciated variability or error in CGM data, and especially when we compare sensors from different manufacturers. And so I think this is really in contrast to hemoglobin A1C assays, which are very well calibrated, standardized, accuracy is monitored. CGM sensors are getting better, they're getting more and more accurate, but the standards for accuracy are actually much looser than what we use for laboratory tests. And there's no governing body that's making sure that CGM sensors from different manufacturers give the same result. So basically, what I'm saying is that if GMI and A1C don't align, most of the time you won't know why, because it could be issues with the CGM, it could be issues with the hemoglobin A1C, or issues with the GMI equation. The GMI equation itself doesn't actually work that well, possibly because it was derived using only one brand of CGM sensors and only in adults.
So then what do you propose instead of the GMI?
Yeah, so I really think we need to shift our focus. It is inevitable that if you keep measuring laboratory hemoglobin A1C and you report GMI, that the values are going to be discordant. And I think when this happens, it's confusing to patients, it's confusing to providers. And I think it is a problem to rely on GMI as a surrogate for hemoglobin A1C because it's not a good surrogate. And I think it confuses things because the real strengths of CGM systems are the detailed data on glucose patterns, the real-time feedback to patients, and CGM systems are especially great for helping reduce episodes of hypoglycemia. So sort of back to your original question, CGM mean glucose is a helpful summary measure, but it's just one metric among many. So I really think going forward, we need to get GMI out of the mix and educate patients and providers about how to interpret all the different CGM measures, including mean glucose. And I just think that creating a second hemoglobin A1C estimate that doesn't agree with laboratory A1C is confusing and causes more problems than it solves.
Okay, so now that you've beautifully outlined the arguments to question the use of GMI, I suspect many of our listeners are really thinking of a few counterpoints at this point. So I'm going to throw some at you and let's see what you think about them. So first of all, the A1C, the laboratory A1C, is also not a perfect test, right? It's impacted by hemoglobinopathies or anything else that could alter red cell lifespan. Also, the glycability, I'm not even sure if that's a word, but I like it. The glycability of a given individual may be different from person to person. So in that case, wouldn't glucose metrics derived from CGM sensor data be more helpful to see what is really going on to help make clinical decisions?
So I agree. Hemoglobin A1C is not perfect, but CGM technology, unfortunately, is also not perfect. So it's just also, I think that people are less aware of the issues and the non-glycemic factors that can affect CGM glucose values. So really, what I think is right now, what is important is to make sure that we are using both laboratory hemoglobin A1C and CGM and doing so in an optimal manner. And so I think the message I really want to convey is that both hemoglobin A1C and CGM are important and both are helpful.
Now, in terms of the issue of discordance, could some of that discordance simply be that the lab-assessed A1C represents 3 months of hemoglobin glycation, whereas the GMI is based on typically about the most recent 14 days worth of data? So therefore, in the clinic, I got to say, I usually interpret the GMI to simply represent what that person's lab hemoglobin A1C would be if they maintained similar glycemia for the next 2.5 months. So then there's a total of 3 months. Then I would see what that number is. So I'm usually not surprised when there is, in fact, a discordance. So what would you say to that?
This is a really good point, but I would say that the studies that have formally compared GMI and hemoglobin A1C, laboratory hemoglobin A1C, have typically used 2 to 3 months of CGM data, and things still don't line up. But you're right. There are lots of reasons why laboratory hemoglobin A1C and GMI don't line up. And I think what concerns me is that there's often been this message that when the CGM data and the A1C don't line up, that there's something wrong with the hemoglobin A1C. And I think this is a problem and it's a misunderstanding. It's just as likely that there are CGM related issues that are causing the discordance. And we can't just assume that the hemoglobin A1C is wrong.
That's a very fair point. And I have to say I'm guilty of that in clinic, right? Because when I see the numbers that they don't quite jive, then I start thinking, oh, I'm going to believe the CGM or, the sensor-derived A1C or however I want to think about it. That's a fair point, very fair point. And then when you talked about CGM mean glucose or suggesting that as a tool other than the GMI, wouldn't that CGM average glucose be fraught with the same caveats as the GMI because it's still based on CGM technology with all of its limitations?
Yeah, absolutely. But I think by discussing both the strengths and also the limitations of CGM systems, I hope we can pressure manufacturers to make this technology even more accurate and better for patients. But you're absolutely right. We absolutely need studies that rigorously link CGM metrics with long-term outcomes and with head-to-head comparisons to hemoglobin A1C. And those are the data that are really missing right now.
This was awesome. Thank you. Thank you very much, Professor Liz Selvin, for sharing your expertise with us today and providing us with a lot to think about. And I think one of the most important things in science and medicine in general is the need to constantly question the established and to recognize the pros and cons of every approach. And I think this whole conversation is a reminder that all the pieces of glycemic information we get are complementary. They're not necessarily competitive, they're complementary. They're telling the story from a different angle, but all with their own limitations. So I think as clinicians with our patients, we're trying our best to interpret the story and then make clinical decisions with all of that in mind. But you've taught me a lot today, Liz, and I appreciate that. And thanks again to you, Liz. And I encourage our listeners to read the full article in the June issue of Diabetes Care.
Let's move on now to our rapid exchange segment, where Alice and I chat about some of the articles we found particularly interesting this month. Alice, what do you have as your first pick?
Well, my first pick for this month addresses a very important clinical topic, which is the use of SGLT2 inhibitors in hospital. Dr. Lakshmi Singh and colleagues from the University of Maryland conducted a nationwide cohort study using data from the Veterans Affairs healthcare system in the United States, looking at acute care hospitalizations from April 2013 to August 2021. They included over 36,000 admissions of people living with diabetes who had an outpatient prescription for SGLT2 inhibitor prior to hospitalization. They compared admissions where SGLT2 inhibitor was continued in hospital, which was about 16% of the total admissions, to those where SGLT2 inhibitor was discontinued. They utilized propensity score matching and adjusted for many covariates, including comorbidities. What they found was that the group who had SGLT2 inhibitor continued in hospital had a 45% lower mortality rate, no difference in acute kidney injury, and slightly decreased length of stay of about 0.2 days compared to those who had SGLT2 inhibitor discontinued. Now, the associations persisted in multiple sensitivity analyses that they conducted. So these data, I think, add to the growing recognition that our previous belief that SGLT2 inhibitors had to be stopped in acute illness may in fact need to be modified.
Wow, that was really surprising and incredible results, Alice, and forcing us to really balance this possible benefit of continuing SGLT2 inhibitors in hospital against the risk for euglycemic diabetic ketoacidosis that can develop with a prolonged NPO period and could certainly be mitigated and managed and monitored for if this really turns out to be a real finding, which seems to be calling out for prospective randomized evaluation. Another outpatient tool evaluated in hospital this issue is the use of real-time continuous glucose monitoring for critically ill patients after major abdominal surgery or solid organ transplantation. Dr. Barbora Baglova-Hager from Charles University in Prague, Czech Republic, and colleagues analyzed data from 61 patients requiring an intensive care unit stay postoperatively with Dexcom G6 sensors placed in the infraclavicular region and sensor glucose compared to periodic monitoring of arterial blood glucose. Active sensor use was 95%, and the mean absolute relative difference between the sensor and arterial glucose values was 9.4%, with patients spending a median 78% time in range and less than 1% time with any hypoglycemia. These excellent results provide validation of the reliability and accuracy for continuous glucose monitoring using an alternative sensor placement site that seems feasible for use in this postoperative ICU setting. So I feel we may be getting closer to a fantasy of mine that we will be implementing continuous glucose monitoring in hospitalized settings as frequently and as easily as we do now with cardiac telemetry monitoring.
And that is an excellent fantasy, Mike, and I think one that will become reality in the future. Certainly, I think we will see it in our careers, and I think it's ultimately going to help patient care, and I think nursing as well, and all of the resources required for the current method of assessing glucose. So this is certainly a space to keep our eyes on. And I'm actually going to continue with the in-hospital theme for this month. So Dr. Rahul Barman-Ray and colleagues from the Royal Melbourne Hospital at the University of Melbourne, Australia, conducted the STOIC-D surgery study, which was a randomized control trial of proactive early intervention with an electronic specialist-led diabetes care model versus usual diabetes care in 1,371 people with diabetes admitted to a surgical ward. The intervention consisted of an electronic diabetes consult within 1 business day of randomization, with recommendations communicated to the admitting team electronically. There was ongoing daily electronic review of the participants' diabetes management with recommendations as required. If escalation criteria were met, then the inpatient diabetes team would perform a bedside consult. The usual care group were managed by the admitting team, and the inpatient diabetes team got involved with a bedside consult only when requested by the admitting team. Over the course of the study, 49% of the early intervention electronic group required a bedside consult, whereas 14% of the control group had a bedside consult. The primary outcome was median patient day mean glucose, and the early intervention group achieved a lower level of 8.2 millimoles per liter compared with 8.6 millimoles per liter in the control group. The incidence of healthcare-associated infection was lower in the intervention group at 11% compared to the control group at 16%. So this study shows the feasibility and benefit of a proactive model of care in appropriate technology-enabled settings in order to provide better diabetes management.
And Alice, it's really nice to see evidence of this electronic model for providing inpatient diabetes care recommendations working through earlier involvement of an appropriate bedside consult when indicated. My next pick comes from Peter Yang at the Centers for Disease Control and Prevention in Atlanta, Georgia, and colleagues who collaborated with the Million Veterans Program to evaluate the genetic risk of type 1 diabetes among more than 100,000 veterans with adult onset diabetes. The authors observed that those individuals with the highest genetic risk of type 1 diabetes demographically resembled those with type 2 diabetes, both in terms of age at diagnosis and body mass index, but were more likely to experience diabetic ketoacidosis, hypoglycemia, early insulin start, and if checked, to have lower C-peptide concentrations and positive autoantibodies against glutamic acid decarboxylase. So these results support that we need to consider a diagnosis of adult onset type 1 diabetes, not just in younger or leaner adults presenting with diabetes, and that perhaps genetic risk scoring might allow us to best identify those who phenotypically may appear to have type 2 diabetes and may be presenting with type 1 diabetes, and really hope to see implementation of the powerful genetic science we've been covering this past year and a half, Alice, in clinical practice.
Yeah, and I think this really highlights that in clinical practice, we often are quick to place a label on someone's diagnosis, but often we are wrong, right? We're finding how different people, their trajectory or their path that they take can be quite different. And then we end up changing the diagnosis for people. And I got to say, these polygenic risk scores are something that I'm looking forward to really help answer that question from a treatment perspective. So yeah, this is another exciting field that we're going to keep a close eye on. Now, my final pick is from Denmark. Mrs. Sherr and colleagues examined nationwide registries to identify trends in the incidence of acute diabetes complications in individuals with type 1 or type 2 diabetes with and without severe mental illness, namely schizophrenia, bipolar disorder, or major depression. Among over 433,000 individuals with diabetes, 9% had a severe mental illness. Risk of hypoglycemia events and the risk of DKA was higher in those individuals living with severe mental illness and the risk of recurrent hypoglycemia was particularly high among those living with schizophrenia. The difference in the rates of acute events between those with and without severe mental illness were highest in younger individuals age under 50. This is a reminder that schizophrenia, bipolar disorder, and major depression are important risk factors for acute diabetes complications, and effective prevention is needed in this population.
And especially challenging, Alice, since, as the authors point out in their discussion, individuals with severe mental illness are more likely to live alone and lack the social support that is so critical for helping those with diabetes identify and address metabolic problems before they become acute complications. My last pick comes from Dr. Soo Hyun Kwa at the Massachusetts General Hospital in Boston, Massachusetts, and colleagues who conducted a time-to-event genome-wide association study for incident cardiovascular disease among individuals with type 2 diabetes. The authors identified 3 novel and 5 known coronary artery disease loci associated with incident cardiovascular disease in this population, as well as when using another polygenic risk score that included 204 known coronary artery disease risk alleles. So we see here again evidence for using polygenic risk, in this case, to identify those with type 2 diabetes at greatest risk for cardiovascular disease who might benefit from earlier, more aggressive prevention effort.
Mike, I think we're just getting closer and closer to that Star Trek dream of just using a tricorder of some sort and then analyzing a person as they walk in and having a much better sense of tailoring medicine to what's going to suit them. So again, something I'm looking forward to. And this brings us to the end of our June 2024 episode of Diabetes Care on Air. Big thank you to Doctors Liz Selvin and Jennifer Sherr and Jeremy Pettus for spending time with us on this episode. Remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes, and thank you once again for listening.